New Zealand's health debate is not really about whether to spend more, but about where the binding constraint sits and which lever moves outcomes. The cost barrier at the GP door, the bed and theatre shortage in hospitals, the workforce deficit that caps everything, the upstream drivers of chronic disease, or the persistent Maori-Pacific equity gap that no reform has closed. The recurring trap is structural. Governments cycle the org chart, area health boards to RAS/CHEs to DHBs to Health NZ, plus a Maori Health Authority to a centralised commissioner, while the real constraints of workforce access and the equity gap stay untouched. The solution space below is organised by lever rather than by structure, because the durable reforms in this theme are the ones that hand individuals a visible entitlement or build durable capacity, not the ones that redraw governance boundaries. Free and expanded primary care access. The co-payment at the GP door is the chief driver of avoidable ED demand and inequitable outcomes. Remove or heavily subsidise the cost barrier. Expand very low-cost access, very high needs funding. Free GP in high deprivation areas. Add capacity through urgent care hubs and telehealth, and demand shifts from hospitals back to cheaper, earlier primary care. Its flagship moves are: expand free VLCA primary care eligibility to all high deprivation, NZ DEP 7-10 areas, fund integrated community health centres and urgent care hubs co-located with social services, universal telehealth option and digital health navigators to extend reach without new buildings, lift very high needs funding and enable nurse practitioners as full first contact prescribers. The central tension, removing the price signal raises demand. Without a parallel workforce expansion, it simply converts a cost barrier into a waiting time barrier, and the open-ended Crown subsidy competes fiscally with hospital and other social spending. This has been partly tried. NZ has steadily extended subsidised primary care by age band and by VLCA practice, and these age-based free visit entitlements have largely stuck because they hand families a named benefit. But universal free adult GP care has never been delivered. The $5 prescription co-payment was removed in 2023, then partially reinstated in 2024, and capitation funding has chronically lagged the cost of delivery, leaving the access gap open. Its durability outlook is rated likely durable. Hospital, specialist and acute capacity investment. Physical capacity is the binding constraint. Hospitals frequently run above safe occupancy thresholds, often at or beyond 100%, with peaks well above. Psychiatric and NICU beds are rationed, and no amount of primary care reform substitutes for inpatient capacity for the severely ill. Capital investment in beds, theatres and specialist pipelines is the lever that moves the acute metrics. Its flagship moves are: capital programme for hospital redevelopment, e.g., Middlemore acute/ICU expansion, and obstetric theatre throughput. Build acute and subacute psychiatric and CAMS inpatient capacity and expand forensic beds. Fund NICU expansion plus neonatal outreach nursing to cut transfers and length of stay. Specialist training pipeline expansion, cardiology, oncology, psychiatry, with retention incentives. The central tension: capital takes years to deliver while the access crisis is now. The same money would fund far more community or primary care interventions, and new beds treat the consequence, a preventable crisis, rather than its upstream cause, while staffing the beds runs straight into the workforce shortage. This has been tried. Hospital capital investment is a perennial, broadly bipartisan activity, but individual projects churn on cost. The new Dunedin Hospital was repeatedly rescoped and cut between 2017 and 2025. Beds get built, but the underlying occupancy and ED target metrics have barely moved, because the workforce to staff them is the deeper constraint, and capital is the first thing trimmed in a fiscal squeeze. Its durability outlook is rated likely durable. Community and step care mental health expansion. The mental health system is rationed to severe acute need and cannot absorb the mild to moderate tier. Build out stepped care, free brief therapy, community teams, 24/7 crisis response as an alternative to police, and kaupapa Maori Pacific providers, intercepting people before they hit acute thresholds and relieving inpatient pressure. Its flagship moves are: fund free brief talking therapy counselling sessions through GP referral, expand community mental health and 24/7 crisis response teams as an alternative to police attendance, roll out the primary mental health access and choice model, health improvement practitioners in GP clinics, fund kaupapa Maori and Pacific mental health providers to serve their own communities. The central tension: The community workforce pipeline takes 5-7 years to grow, so short-run demand cannot be met by training alone. Community models suit mild to moderate need, but cannot safely substitute for the inpatient capacity the severely ill still require, making this an and, not an or, against acute investment. This has been tried. The 2019 package funded the Access and Choice primary mental health model, which placed health improvement practitioners in GP clinics and has been retained by the subsequent government, rather than reversed a genuine capacity build that embedded. Delivery, though, lagged the headline funding because the workforce did not exist to spend it, so the unmet need metric improved only modestly. Its durability outlook is rated likely contested. Upstream population-level prevention. Chronic disease is manufactured by the social and physical environment, so downstream treatment is necessary but never sufficient. Act on the drivers. Restrict unhealthy food environments, fix damp/cold housing, build walkable neighborhoods, sustain smoke-free generation measures and school well-being, cutting incidence at the population level with the biggest gains in the most deprived communities. Its flagship moves are: restrict fast food outlet density and advertising near schools, 500m exclusion zones via planning. Subsidize healthy food access and link housing warrant of fitness enforcement to addressing damp and cold. Smoke-free generation policy and tobacco/alcohol availability controls. Evidence-based well-being curriculum and early intervention in schools. The central tension. Benefits accrue over 10-20 years while political and funding cycles reward short feedback loops. Commercial food, tobacco and alcohol interests mobilize hard against restriction, and because the payoff is a diffuse public good with no identifiable individual beneficiary, it has no defending constituency when budgets tighten. This has been partly tried, mixed and instructive. Healthy homes rental standards stuck, but the world-leading smoke-free generation law was passed in 2022 and repealed by the next government in 2024, before taking effect a textbook late term. Single coalition reform reversed for fiscal and ideological reasons. A sugar tax and food marketing restrictions have been recommended repeatedly and never enacted, blocked by industry and the long lag problem. Its durability outlook is rated likely contested. Chronic disease management, early detection and first 1,000 days investment. Given the disease burden already in the population, the highest return clinical lever is detecting and managing conditions, earlier nurse-led chronic care programs, community pharmacist prescribing, targeted screening in high-risk Maori and Pacific communities, and intensive wraparound support in the first 1,000 days, reducing hospitalization within years rather than decades. Its flagship moves are: nurse-led diabetes and cardiovascular care coordinators in high-needs practices, community pharmacist prescribing for stable chronic conditions to add access points, targeted HbA1c cardiovascular screening for high-risk Pacific and Maori populations, free midwifery, healthy home retrofits and integrated parenting hubs in the first 1,000 days. The central tension. Management accepts and locks in the existing disease burden rather than preventing it, the standing fight with the upstream prevention camp. Scope of practice changes for nurses and pharmacists move slowly through professional bodies, and the first 1,000 days payoff, though large, manifests over 20 years, beyond any electoral cycle. This has been tried. Nurse-led chronic care management and expanded pharmacist/nurse practitioner scope have been progressively adopted and broadly retained across governments as uncontroversial clinical efficiency, though scaled unevenly by region and capped by workforce. Targeted ethnic-specific screening has been piloted repeatedly with good evaluation results, but not universally funded. First 1,000 days wraparound remains aspirational and fragmented across health, housing and social agencies. Its durability outlook is rated likely durable. Health workforce pipeline and retention. Workforce is the binding constraint behind every other lever-free GP care. More beds and community teams all fail without staff. Grow domestic training places, bond graduates to rural and underserved areas, fast-track international medical graduates for the short run, and build the Maori and Pacific workforce as both an equity and a structural fix. Its flagship moves are: expand medical and nursing training places with targeted Maori and Pacifica entry pathways, rural bonding schemes, forgiven loans, housing support for GPs and nurses in underserved areas, fast-track registration and settlement support for international medical graduates, mandatory rural clinical placements, and a third medical school rural training pipeline. The central tension. The domestic pipeline pays off over 5-10 years while the gap is acute now, forcing reliance on international recruitment that depletes lower-income source countries and does not build domestic capability. Bonding schemes have high overhead and patchy compliance, and trained staff keep leaking to Australia and private practice regardless of how many are trained. This has been tried. NZ has run rural bonding since 2009 and periodically lifted training intakes, with a third Waikato Medical School approved in 2025, all broadly bipartisan capacity investments that get inherited and continued. But the vacancy rate and rural gap have not closed. Training expansions are slow, retention against Australian salaries is weak, and the system has leaned heavily on IMGs, who now make up roughly 40% of the doctor workforce. Its durability outlook is rated likely durable. Maori and equity-focused commissioning. The Maori health gap has persisted through every structural reform because mainstream services underserve Maori. The answer is to commission care differently resource kaupapa Maori and Pacific providers who consistently outperform on Maori outcomes, weight funding to deprivation, and give Maori a decision-making role in what is commissioned for their communities. Its flagship moves are fund and expand kaupapa Maori and Pacific health providers and community health workers, weight health funding toward high deprivation populations and the Maori Pacific gap, devolve commissioning of Maori health to Maori-led entities, the iwi/locality commissioning model, embed cultural safety and Maori health workforce development across mainstream services. The central tension. This lever sits directly on New Zealand's sharpest values cleavage targeted by Maori for Maori provision versus a universal one standard of citizenship health system, so the structural/governance version provokes the strongest organised reversal, even though the provider funding version has quietly operated for decades. This has been tried. The standing co-governance version was tried and churned fast. The Maori Health Authority lasted barely 2 years, 2022-2024, before disestablishment, a textbook late term, identity-laden machinery reform on the values cleavage. The quieter, non-structural version contracting kaupapa Maori and Pacific providers has run since the 1990s across governments and survives because it is provider funding rather than a constitutional governance claim. Its durability outlook is rated likely reversed.